So let's go back to the other AC, the ACO model. Ateev, maybe I'll ask you this. As I sort of summarize what you hear about ACOs, some are saving money, but maybe not enough to reap the benefits themselves. And of course, we have two different types of models. We have the shared savings model, and I think I was talking about that, but also the Pioneer model, where a number of the original Pioneer ACOs dropped out. Thoughts on the concept of the accountable care organization as it's played out in Medicare's rendition?
So I think that just to emphasize and echo a couple of thoughts that you've had. So on one hand, you could argue that the ACO program has been successful. In that, in aggregate, many of the ACOs are decreasing costs. Quality has improved. We're seeing one of my colleagues, Michael McWilliams, published a piece showing that patients seem to be happier when they get care at an ACO than they would have been if they had not been a part of an ACO. So I think there are a lot of benefits. But I think there are several concerns, and just to emphasize those. First, I've already emphasized one of my concerns, which is about market power and what we're driving through the ACOs. But I also think that in terms of how they've actually been implemented, as all of the panelists are well aware, there's been a lot of criticisms in terms of how they've been implemented, what's the level of risk, how you attribute patients, and so forth. And it could be just seen as like, oh, the devil's in the these are just details, but that's really, I think, a key issue. This next generation ACOs to try to allow for a path between the shared savings program, Pioneer, next generation to Medicare Advantage, and to try to allow providers to take more and more risk. And I guess we'll see if it's successful. I do hear a lot of grumblings about the way that Medicare has implemented these programs and that are really undermining their ability to really improve the health care that they're providing to patients.
I would just make a comment, whether it is a government program type ACO or any ACO, and the topic of risk, assuming risk. There are some incredibly sophisticated health delivery systems that know how to assume risk. They know how to deliver care in such a way that they will probably make money off of the system and risk won't even come into it. But to any of the physicians and the smaller hospitals out there that are thinking of taking on risk, get yourself well informed, get a consultant involved, learn as much as you can about it, go slowly with taking risk. I think that there are many providers who are very bright, very hardworking, and think they understand the implications of taking risk. But once they've signed those documents, they may be surprised by what eventually happens.
Sure, and that of course was a concern that with the managed care movement of the 90s, the degree to which providers were prepared to take on risk. But Francois, earlier I think I heard you say that there are some kind of novel arrangements now where risk can be managed through reinsurance programs, and those reinsurance programs aren't just for the most catastrophic cases, maybe for episodes or bundles or specific clinical conditions and such. I mean, speaking to Art's point, is it as challenging as Art suggested, or are there some kind of solutions on the horizon to help providers to be better equipped to take on risk?
Well, there's solutions, but you have to decide what kind of business you want to be in. And do you want to be in the business of taking on financial risk that is purely insurance risk or variations of insurance risk? I mean, is that what you want to do as a business, if you want to think about a provider organization as a business? Or do you want to prefer taking on risk that's more associated to your technical expertise, the ability with which you can manage patients more effectively, reduce infection rates, and so on? And there just isn't that. I don't think we've had, as a country, enough of a intelligent dialogue about the differences in these risks and how to create boundaries around these risks. Because if we did, then I think you would see, for the most part, physicians saying, I'm willing to take on a lot of risk around my capabilities as a physician to manage my patients. Well, what's this insurance risk thing that you keep talking about? Well, it's the risk that your patient might have. You have a few more patients who end up by having cancer, and we can't really case mix adjust that, so it's, tough luck. And most physicians would say, no, that's not my job. I don't want to take on that risk. I want to take on the risk associated to the proper management of my patients. So instead of hiding these things and saying, let's call it an ACO, let's call it population health, and dump that risk on a third party, let's understand the implications of the different types of risks that exist in healthcare, how to apportion them appropriately. Those who want to take it because they feel they can manage it, great. And if they want to find a financial layer of reinsurance, then that's good. Those that don't shouldn't be forced to, but there are clinical, technical management risks that they absolutely should be held accountable for.
So we need a transparency tool for risk-taking, it sounds like.
Well, we need a tool to better. I mean, I don't think understanding risk is that difficult. I mean, in pure economic terms, it's relatively simple. But the dialogue is not about that, right? Mm-hmm. The dialogue assumes that these things are readily interchangeable, and they're not. And so let's just have an understanding of what drives the tail of a distribution and how much variability is there that's controllable and not controllable, and where do you want to put the boundaries of that risk taken?
And I also just should emphasize that it is, we also have to be realistic, that let's say an organization that's pretty savvy, understands what risk-taking is, has the capacity to take the risk. It's very, very difficult to take an organization that's been built for 50 years on one model and shift it to another model. I'm part of an ACO, I practice in an ACO, but at the end of the day, I'm not sure that in terms of the care delivery that I provide, has changed sufficiently in any observable way from my end as a doctor than it was 5 years ago when we weren't part of an ACO. And it's not a criticism of my organization, but just really what I want to emphasize is how difficult it is to really transform a way an organization delivers care. It just does not happen overnight.
Well, not only a care delivery organization, but even an insurance organization. So we tend to think of insurance organizations as taking on risk, but we know that in many cases they administer plans for self-insured clients.
Sure.
But now